Okay, we're ready to go.
Great, thank you, Casey. Good morning, everyone. My name is Elizabeth Murphy. I'm the Director of Creative New Jersey. And along with my colleagues, Casey O'Brien, Jeanette Mitchell, and Alyssa Calderon, I'm so pleased to welcome all of you to this morning's gathering. It's great to see so many friends joining us again. As many of you know, today's briefing is the 9th in a series of statewide calls regarding COVID-19 response in New Jersey. So every Wednesday, beginning April 1st, we have gathered via Zoom from 10 a.m. to 11 a.m. to hear updates on statewide efforts, to share news on resources, and to help people and organizations keep connected during this really difficult time. These gatherings, like all of Creative New Jersey's programming, are open to everyone who wants to participate. We're certainly grateful to all of you and so many others over the last couple of months who have participated with us. Thank you for sharing your knowledge and your time. Thank you for being the bedrock of our statewide community and for all that you do to make New Jersey a better place to live and work. Before we introduce today's speakers, Casey and Jeanette and Alyssa and I wanted to take a moment to acknowledge the murder of George Floyd and the national groundswell of support for racial justice in our country. We know and we recognize that many of you on the call this morning, alongside so many others in New Jersey and beyond, have been working tirelessly for decades to bring about racial and social justice. For us, two of our core founding principles at Creative New Jersey are diversity and inclusion, and our mission is directly tied to fostering creative, collaborative, and equitable community-based solutions in our state. So we posted a statement on Monday, and we just wanted to share it with you now. Creative New Jersey denounces racism, racial injustice, and all forms of violence, discrimination, and bigotry against people of color. We stand in solidarity with our Black friends, colleagues, and communities. The horrific racial injustices, hate crimes, and deaths that continue to take the lives of innocent Black Americans must end. We reaffirm our commitment to justice and fairness for people of color, and we lean in hard to our value of bringing highly diverse groups of people together as a force for good in the world. We promise to work even harder at building connections and networks that strengthen the fabric of humanity in our state, and to building bridges to knowledge and resources for the equitable benefit of all people, especially for people who are most affected by systems of discrimination and oppression. To our statewide Creative New Jersey family, we are holding space for you, and we are here to listen, support, and act with you. We thank everyone who joins us in lifting up the values of creativity, inclusion, and collaboration for a more equitable New Jersey. So we're going to ask us all to just take a moment of silence in honor of George Floyd, Ahmaud Arbery, Breonna Taylor, and all of those before them who have lost their lives. Thank you all. So today, we're very grateful to our colleagues at University Hospital and Treehouse Cares who have agreed to be on the call with us this morning to share their knowledge and their expertise. It's my great pleasure to introduce our first speaker, Dr. Chris Pernell, who is Chief Strategic Integration and Health Equity Officer at University Hospital. Dr. Pernell is going to share from a health and clinical perspective about what we've been learning around COVID-19, what we might be able to put into place to help build resiliency in our urban centers, and some other information that we know will be helpful to all of us on the call today. So Dr. Pernell, you can unmute yourself. I think you are unmuted. I know everyone joins me in welcoming you. Thank you for your time, and I'll turn it over to you.
Okay, great. Good morning, everyone. I'm very, very happy and honored to be with you this morning in what I hope really is a back and forth dialogue, right? Not one person, not one institution, not one field or profession has all of the answers, but we have insights, right? And we each have unique insights that will enable let's say, a more empowered whole for how do we build resiliency in our communities? How do we build resiliency specifically in urban communities? And how do we build resiliency in communities that have borne a disproportionate burden because either of the pandemic of COVID-19 or the pandemic of systemic racism or the pandemic of multiple comorbidities that these same Black and brown, vulnerable, disenfranchised, disempowered immigrant communities where English is a second language, our LGBTQ communities, how do we begin to build within the system resiliency? Too often the conversation around resiliency immediately goes to the individual, right? What can the individual actor do to live a more resilient life? What are those behaviors? What is that approach, that mental model? And I would like us to step back and say, what can the system build to actually cultivate and foster resiliency that then encourages or influences behaviors and choices, okay? So that's just where I'm starting from, the foundation. And I want to tell a little bit of a story, right? Because the power of narrative to communicate, the power of narrative to inform, the power of narrative to really excite us to think creatively around a particular problem, barrier, challenge, or issue, and to begin to solution, I think is so fitting. And even this weekend, I'll speak personally, I used narrative, I used a poem to express what I was experiencing because of the murder of George Floyd, right? And I have a history and a background of being a spoken word artist, and especially through faith-based communities. So I went back to my art. I went back to my creative engine to begin to speak to what I was experiencing and calling for a call to action. And so just using that as a lens to tell this story. So I am true a hospital administrator. I am true a public health physician, but I am a daughter of a person, a father who died to the COVID-19 pandemic. And I'm also a sister of a breast cancer survivor who got infected with COVID-19. So when I'm talking about resiliency, I'm coming to it with personal insights as well as professional insights, right? So as you know, New Jersey, and in particular Newark, has been at the epicenter of the COVID-19 pandemic. And I want people to understand that it's still happening, right? While we are not at the peak, while we are not at the surge of cases that we originally saw, and thankfully so, there are people still being exposed, there are still people testing positive, and there are still people dying from COVID-19. The economic impacts are definitely still with us, as there are non-essential businesses that are now just starting to come back online or to have plans to come back online. So there's an economic impact, and there is a social, a cultural, and a political impact. So this pandemic is very much still going on. So what did University Hospital see? So University Hospital is, we are hybrid, right? We are the state's public academic medical center, and we're also a community hospital, right? Vested in our mission and our mandate to serve the Newark community. We grew out of the uprising and upheaval that happened in the late 60s, and that those agreements, the Newark agreements and Newark Accords, to provide high quality care to communities that have been disenfranchised or that have been impacted by structural racism. So that's what we wear on our backs, right? That mission and value. So here we are with that mission and value, and we're sitting at the epicenter of the epicenter, if you will. At its peak, we probably had our first diagnosed patient roughly, without having the exact date in front of me, early March, right? But we had been in planning phases for quite some time, for a couple of months prior to having that first diagnosed patients, especially because we are the state's only public academic medical center. We had that first patient, and if you go a span of the month to about April 9th, when we hit the very peak of how many patients we had in the hospital who were COVID-19 positive, well over 200 patients who were COVID-19 positive. And if you can imagine what that meant for the institution, and I want to use it as a microcosm of what it meant for a community, right, to experience something similarly, because we are a worker community here. And so here you have us, used to serving a certain community, meaning a community that's been saddled with multiple comorbidities. They're medically, behaviorally, socially complex, right? And now there is another layer thrown on top of that. So we immediately have to have a response that's adequate, not just to the clinical aspects of it, right? And that clinical aspect of it was constantly evolving, constantly changing. The CDC and the New Jersey Department of Health constantly articulating and putting out guidelines. So think about how organization has to be resilient as guidelines for caring for a novel virus emerge. And think about then how communities would decipher that information. If I can tell you what it's like for an organization to attempt to decipher that information, where that data was changing on a rapid basis, sometimes daily, imagine how a community person who had a different sense of literacy around the issue, what they were hearing, and perhaps the confusion, not perhaps the confusion that it engendered. And then I want you to layer on an issue of broken trust, right? In particular in Black and Brown communities. So imagine a fast-paced environment where the scientific data is constantly changing, but you don't know if you quite trust the resources that are giving the information. So how does that impact your ability to prepare? How does it impact your ability to plan? So I say that because we at university had to think about all of those things at once, right? How do we deliver high quality clinical care as the information and the data is changing? How do we make sure that we have appropriate resources and to do an appropriate response, just as households were under this strain of resources, right? Do I work in a frontline position? Perhaps I'm in an economically vulnerable household. I can't afford to stop working, although there is a stay at home, right? So I take that risk and I continue to work. Or do I work in a frontline position where I don't have paid sick leave, where I don't have the benefit and the privilege of telework, right? So while families were dealing with that, we were dealing with that here at university, because we have a certain amount of frontline workers who have to be physically in the hospital. And then we had others who could telecommute or telework, right? So these were the myriad choices and decisions that we were faced with. Do we have adequate resources so that if we were to get in a situation where the patients who presented to the hospital were more than the capacity to treat them? Thankfully, we didn't get there, but did we get full like a balloon and were we at our seams? Yes, meaning getting in resources to provide care. Had not the Department of Defense provide almost 90 DoD personnel, whether they were physicians, whether they were nurses, whether they were respiratory therapists, whether they were clinical psychologists. We were what we call staffing extremists, right? We're at the very edges of our ability to provide care. So you had providers in very unfamiliar situations. And I say that because just like you had providers in very unfamiliar situations, you had the community, the public in a very unfamiliar situation. There wasn't any aspect of University Hospital that was not impacted by the coronavirus pandemic. We saw similar demographics that the state started to report around who was being exposed and who was being infected. A higher percentage of those who identified as African American or Black who were being infected. Another high percentage of those who identified as Latino or Latinx or Hispanic who were being infected. We did see a higher percentage of male to female higher than what the state is almost equal, like in the high 40s for male and female. We were definitely a majority male. Our median age was a little bit older than the state, right, 62, but that doesn't mean we didn't see patients in every age range. So we're dealing with this complex moving target of being able to take care of everyone who came in. We had to consider rationing or resource allocation frameworks that I was very much a part of. And how do you ensure that communities that have been burdened by the legacy of systematic or systemic racism aren't then further impacted by not having access to resources should those persons get to the point of needing critical care and needing ventilators, right? And so I give you an organizational scenario because there's always an individual or community scenario that is similar. In the community, you're not thinking explicitly perhaps around, okay, do I have enough ventilators? But you're thinking, do I have enough food? Right? Food insecurity. You're thinking, do I have, if I needed to get to care, am I able to get to care, right? I'll tell you the experience of one of the workers, our frontline workers here, because he lived in New York and the ability to get to work, you can imagine, was very difficult. He ended up taking a boat, right? He was boating to work, in a combination of taking a boat and, docking in the harbor, and then from there, finding his way to get into the hospital. So imagine a frontline worker who may not have the same means in a different scenario think, okay, I need to get to work, but how do I get to work? Public transportation is not as available. And so I wanted to level set that way to say whether you are an organization, whether you are a person living in community, we face similar scenarios, but the perspective of it was different. And especially because University Hospital is situated in Newark, New Jersey, how we experience that would be different from another institution situated in a community of different economic means, in a community of a different historical legacy, of a community of a different socio-economic background, a community with different ethnic and racial makeup. Right? But what did we do to not only survive, but to thrive, right? There was this constant sense of having data to inform rapid decisions and then having a reflective period, right? To say, was that guidance, was that policy appropriate? Did it meet the demand or did it meet the need? Or how do I change it? There were so many policies that were reimagined because of what we were faced with, right? So immediately we had to go to where we had to restrict visitors into the hospital. So that was painful. That was painful for patients who were sick, and that was painful for loved ones who couldn't have access to their family members, and especially around those who were dying. It was difficult. I experienced it myself, right? I couldn't see my father after probably was around March 13th or so, was the last time I saw my dad. My dad died on April 13th, right? So it's like families were experiencing this sense of separation, right? As an equity doc, I don't say social distancing, I say physical distancing, because it's very important that we all understanding that social connectivity is paramount. It is fundamental to good health. It is fundamental to health and well-being. Whereas physical distancing communicates there needs to be a physical separation of 6 feet. We need to find ways to keep people socially connected. And so as I fought for ways to stay socially connected to my dad, emotionally connected to my dad, we were thinking about our families here. And through donations, the Newark community, whether it was organizations like Audible or organizations like Prudential or local churches or just citizens, we had an onslaught, an overwhelming response of how do we help University Hospital. So we received donations of devices. So we had to think about how do we become a more virtually connected health institution. And we aren't of the wealthier academic medical centers. Let's just put that out there, right? So immediately we're trying to say, how do we keep family members in touch? How do we give out cell phones to our patients who have been diagnosed with COVID-19 or under suspicion of COVID-19? But then how do we ensure that families can still not only just speak to the patient, but speak to the care team? right? So there were a host of issues that were going on, providing high quality care in the midst of an epidemic, you being the epicenter of it, resource constraints, fast changing guidelines. Then there was the social emotional aspect of it, having a visitor restriction policy, which means that patients and loved ones could not communicate. How do you try to bridge that gap, right? And how do you try to throw into a system virtual connectivity overnight? And not to ignore, but to think about our staff, right? And saying, how do you continue to provide a safe work environment and a positive work environment in the midst of an unprecedented public health crisis? How do you do that? And so we had to build within the system opportunities for resiliency for our staff. You know, mental health first aid, psychological first aid is something that's increasingly spoken about, but definitely still we don't have, let's say, pervasive understanding of exactly what that is. But through our chaplaincy director, through some of our clinical leaders, we had to raise various ways for staff to process, to understand what it meant to provide care in a resource constrained environment, meaning you were taking care of more patients than you normally take care of. The patients were sicker. Some persons described it as being in the midst of a battlefield, multiple codes happening at the same time and feeling limited. And so we, whether it was through virtual, we had to, devise WebEx reflection groups for people to just get on and reflect and to process what's happening. We did a lot of peer-to-peer support rounding, whether that was one-on-one or in the group setting. The impact of recognizing those in our families that we lost. University Hospital, we lost, I think at this point, 10 persons to COVID-19, right? Staff, people who have worked here, who were the lifeline of this fabulous organization. So how do you process and deal with grief? So I say that to say that's also what community is dealing with. I've dealt with it personally. How do you deal with and process grief? Losing a loved one during a time like this, you can't mourn as you would normally think you could mourn. You can't hold a funeral service as you normally would. So how do you give people space to heal from trauma, not only just to process it, but to heal from trauma? So that's something that we've had to think about in the organization. And the last thing I'll say, just because I want to definitely allow this conversation to build through some questions, as we saw that ourselves come down from that peak, right? So I said, beginning of March, our first diagnosed patient, beginning that first week around the 9th of April, we're at our peak, and to where we are now, less than 40 patients in the hospital who have coronavirus. How do we still get community to come back to care? I'll share two stats with you. Across this period, if you looked across February to May, we had a 44% drop in heart attack and stroke encounters coming into our ED. That did not mean that people were not having heart attacks or people were not having strokes. That meant that people were not coming to the hospital, even with emergent situations such as that. Our EMS, we have something called a DOA run, right? A dead on arrival, meaning you respond to a call. And when you get there in community, the patient has already passed or the patient is dying. If we looked at a comparable time from mid-March through to the end of April, those runs increased by 195%. That's staggering. That is staggering, right? So not only, and that was irrespective if a person had COVID-19 symptoms or not. So not only are we now dealing with the pandemic itself, we're still dealing with those complex comorbidities that existed before the pandemic. I heard a great organization say, and I've adopted it myself, there were cracks and fissures in society that through COVID-19 became earthquakes. If you before thought you could talk about disparities or health equity from a dispassionate place, it would be hard to do that now, right? Because we realized decades worth of research in 2 to 3 months. right? And so how then do we reassure community that it is safe to come back to the hospital? You know, we've taken every precaution, whether it's, and this is different, right? This is a part of resiliency. We do different behaviors now. Everyone who comes into the building here, you get a temperature screen. You get certain questions asked about symptoms. You must wear a face mask, a surgical mask, like we all walk around it with these, regardless of whether or not you're patient or not, right? And so that's something that community is dealing with too, right? Masking up, not being able to go into stores without a mask on, disinfection processes, terminal cleaning aggressively, cleaning high touch surface areas, you know, physical distancing, as I described before. We just were allowed to resume elective cases. So making sure you have all of the protocols in place to safely begin to approach an adjusted normal, right? Because our lives will forever be different because of COVID-19. So I just wanted to tell that story in that way, just to perhaps inform some specific questions you may have and to be able to tell the dialogue different. But just to synopsize again, you're in the middle of a pandemic. You are the epicenter in a chronically disenfranchised community, bearing the burden of structural and systemic racism. How do you still provide high quality care in that fast-paced moving environment where information is changing? Then how do you maintain a safe and provide a safe and positive work environment with people who have experienced trauma? And then finally, how do you begin to reassure community to return to care even as the pandemic recedes? So those are also the three things that community is equally dealing with in this urban environment. So I'll open to questions or dialogue, insights, whatever you may have.
Thank you, Dr. Pernell. Thank you so much for all of that information. And, you know, first, let us just say we're so sorry about the passing of your father.
Thank you. Thank you.
We're very sorry.
Thank you. Thank you. But I tell that so that people understand, you know, when we say COVID landed on the Black and Brown community, it landed on the Black and Brown community because we were already bearing disproportionate burdens related to racism. So higher disease burdens already, chronic comorbidities, you know, less access to care in a timely fashion, you know, economically vulnerable households, working in frontline jobs where you couldn't stay at home as quick as another. So I say that to say, when we say that it impacted the Black and Brown community here, it's myself, a woman of certain socioeconomic status. I had a sister who was infected with COVID-19 and is still in the recovery phase, which is very difficult, I tell you. And then I lost a father to COVID-19. So that's what's happening outside of these four walls.
Yeah.
That's what's happening.
Thank you for sharing all of that with us so personally. I'll turn it over to my colleague, Casey. Casey, as many folks know, will moderate this Q&A, and some folks might have some questions for you now, Dr. Pernell, and sometimes
Sure.
a little longer. So we'll see what we'll see what folks have to say, and let Casey take it away.
Great, thank you, Elizabeth. So yes, just as a reminder, folks, you can drop questions into the chat function. If you're joining us by computer, you can also raise your hand by clicking the little blue hand icon in the participants section. For those of you, for the couple of folks who are joining us by phone, you can also hit *6 to unmute yourselves. So, you know, feel free to ask your questions in those three ways. And I'll just keep an eye out for those coming in.
I have a question for you. While
Sure.
While some folks might be formulating their thoughts, does the hospital work with other nonprofit organizations in your work around messaging to the community and reaching out to the community?
Definitely. So let me talk about that specifically. So we launched at this point about 3.5 weeks ago an initiative called Care Around the Clock. So Care Around the Clock is a patient and community engagement strategy to reassure patients that it is safe to receive care and to disseminate information around COVID-19, and then to disseminate information around health and well-being. When we raise something like that from the ground, right, because it didn't exist before, and trying to get our message out. Remember, I said in communities where trust has been impaired, especially how racism has impacted how Black and Browns experience trust of healthcare systems. We need trusted resources, messengers to help communicate with the same voice, right? So definitely through our faith-based communities, we tapped into faith-based communities when we launched Care Around the Clock, saying, hey, this is the information that we're trying to get out to community to tell people, if you're having serious symptoms, please return to the hospital or call 911 and go to the ED. And so who else can become a messenger for you becomes very critical at a time like this. What are the relationships you have? Thinking now through our, I should say even before that, with Care Around the Clock, we did mass emails to patients. That's the first time we had ever done that, right? We did a lot of firsts. We communicated to over 9,000 patients through an email. That was the first time. We started to create video messages that we could also send out through these waves, or attach these messages to other community-based organizations. We have a connected@uhnj.org for people who want to be connected to University Hospital to learn information. We've asked our community-based partners, either these were partners that had sponsored sessions where our CEO had gone in and taken questions from residents to help us get this word out. We're doing Facebook Lives with their CEO and different panelists every Thursday practically. And we've asked different community-based partners to either join those or host watch parties. So definitely we're thinking about what are those tentacles in community, right, that help us build a more effective and resilient web. And that's going to be how life is lived going forward. We can afford to go back, and we can't go back. It's a broken trail. There's no way to get back to where we were. So however we can make those connections more robust, more muscular, we're seeking to do that. We're doing PSAs, everything that you can think of, and making sure we're doing it in more than one language. Spanish-speaking audiences, Creole-speaking audiences, we cannot go back. People have to give information. They have to get it in a timely fashion. They have to get it through multiple modes of communication channels, and they have to hear it from people.
Yep. Thank you. That's all great. And I know that we've probably got a few folks on the call today who might want to get more connected to that Care Around the Clock effort that you're doing. So I know there's a bunch of questions in the chat function. Casey's going to read some of them out, but I want to just do a time check because we have another speaker, Tanya Veltz, and it's 10:37, and we want to make sure we have enough time for Tanya, and we can always circle back to some more questions for Dr. Pernell, but I think we can only take another 3 or 4 minutes right now, and then we're going to go to Tanya. But Casey, go ahead. Do you want to read some of the questions?
Sure. Yeah. And I think a couple of them are sort of on the same wavelength. The idea of, what do we need to have in place if there's a second wave for this crisis, including things like how do we get testing to vulnerable communities?
Yes.
And how do we get critical stakeholders involved in this process?
Okay, so let's talk about what do we do with the second wave, because that's also related to testing, right? So where we struggled as a nation in our public health response, we did not start testing soon enough, and we did not test widely enough. Right. So now what you see is a very aggressive ramp up of the availability of testing. There is testing provided through the county. Essex County is providing testing through drive-through sites or walk-up sites. The city of Newark is providing testing. We're starting to look at our capacity and say, yes, if you come to the ED, if you had an emergent case, you're going to get tested, right? And if you were going to get admitted to University Hospital, at this point, everyone was getting tested. But are we able now do we have capacity to say I'm asymptomatic and I want to get tested? So we're having conversations with city partners. How do we become a designated testing site for others in the community? So more widespread testing is going to be important. Contact tracing is going to be very important. Understanding how do you map out and diagram persons who may have been exposed and others that they may have been in proximity to. But we have to understand, what does that mean to the community when you say you want to do contact tracing, right? Especially in a community where there has been broken trust, right? How do you explain that? How do you still respect privacy? So we have to build up that prevention force, and we have to figure out how to get care to where people are. I saw a question about people being scared to come back to the healthcare provider or the healthcare setting. telehealth has to become the way of life, right? So do community have resources to ensure that they're able to be connected virtually? We, alongside Rutgers, New Jersey Medical School, sprang up telehealth literally overnight. Before, we were taking our time, we were thinking through it methodically, but there was an immediate need. So around mental health and behavioral health, almost all of those appointments transferred to virtual telehealth connections. And even now, we're seeing some practices where people are slowly starting to come back to care with in-person while making available telehealth options. And the last thing that I'll say, we have to think about ways to do in-home and tele-monitoring. How do we get that to vulnerable Black and Brown communities, meaning ability to check their pulse ox if they have COVID-19 or some other respiratory issue, the ability to check their blood sugar, the ability to check their blood pressure, and then communicate these things back to a provider. That has to become a way of life.
Thank you, Dr. Pernell. Thank you for that. I know that we've got a couple of other questions in the chat function, but we're gonna turn to our second speaker now, and then I think there might be some time for some more Q&A after that. So I know everybody thanks me or joins me in thanking you for your time. Really important and helpful information this morning. So now it's our pleasure to introduce our second speaker, Tanya Veltz. Tanya is the founder and director at Treehouse Cares, which is a community health program in Newark. So we know that they were able to ramp up very quickly to respond to the pandemic, and we're really grateful to Tanya for being with us today. I know everyone joins me in thanking you. Yeah, I'll turn it over to you.
Well, good morning, and I just would like to say thank you. I'm going to quickly speak. I'm going to explain who we are and what we do, and my experience so far with COVID-19. I have to pick up some donations in about a half hour, so I'm going to kind of rush this along. So as you mentioned, my organization is Treehouse ENT Cultural Arts / Treehouse Cares. We are a community outreach organization that provide food, clothing, and other resources, sustainable resources to those in need. We've been operating for almost 4 years now, and since COVID-19, we have been going nonstop. My experience with it so far is that usually we service roughly around 200 to 300 people per week with food and other essential items. This has amped up to 500 per week, and we provide hot meals and deliver to seniors and disabled, and that's at 400 per day. And the reason is because people have lost jobs, they've had deaths in the family. It's all kinds of situations. I was tested last week for COVID-19. I just wanted to know because I'm out there. We service the homeless population also, and we've been out there nonstop for a very long time, so we wanted to know. So my test came back negative, but I had positive antibodies, which for those who don't understand, that means that somewhere along the line, I was infected or was exposed to it. Had I not known the medical terminology to what that was, it would have scared the crap out of me. And my personal opinion is that these testing sites are great, but when you have people who are not educated as far as is what they're offering right now, I think they need to better explain when you say positive to somebody, rather they have negative results. I think they need to explain a little bit more of what the details are in that. Again, had I not known, and I also reached out to my son's girlfriend, who's a medical doctor, and she broke it down to me that I am pretty much in, I'm not gonna say a better position, than someone who's tested negative all the way around the board, meaning antibodies and COVID-19. But from what we're learning, that is basically that my body fought it off, and you build up some type of immunity. And this, to me, I don't know, Dr. Pernell, if you would agree, I think that these testing sites need to have more information, not just swab and do the immunoglobulin test and then just say, okay, you're negative. But it needs to be more explained at the sites of what actually, what the results actually mean. Since I've been doing outreach, we're nonstop every day. I think I take off Mondays because as requested by Mayor Ross Baraka, we honor Be Still Mondays, which gave us a break. But it's been nonstop, and not only do we service people with food and clothing, but I actually sit and listen to the situations, and we try to partner with other organizations, which have been a tremendous help. People really don't understand how important partnerships are. We've been able to service, provide just a ton of resources, and you kind of like become a psychiatrist yourself because you're listening to all these people with their grievances, with their problems, and it's so overwhelming and so confusing. Like, I try to stay abreast as much as possible because the information, as Dr. Pernell said, it changes from day to day, and you have to figure out how to do what you do and do it safely, and at the same time provide the services that the people need. So that's my experience with COVID. I've lost friends. I'm gonna be very honest with you. If I wasn't doing outreach every single day, I think I would be a basket case. I think I would literally sink into a depression because with that and the Black Lives, so much stuff, the racial tension right now and all the things that are going on around the world. I think that at the end of this, I am going to have to go and seek mental health, and the outreach keeps me going. It's really depressing. I try to stay off of social media other than, to inform people of what we're doing and how they can come and receive help. I'm constantly posting on my pages where people can go and get food and even medical resources and housing and all. That's what I'm doing. But otherwise, I really, it's so depressing. It's really depressing right now. So, that's my experience with it so far. The numbers are growing. The numbers are growing, not with just COVID-19, but the results of people just suffering and just experiencing all kinds of hardships at this time. So, I don't know, what else to say. It's just a sad thing. The world is like in an uproar right now. And I'm sorry for your loss, Dr. Pernell.
Tanya, thank you very much for sharing with us this morning your perspective, and your perspective is so important for all of us to hear and understand, and the work you're doing at the local level is really tremendous. So, I hope that, your sharing with us today has inspired some other folks on the call today to figure out how they can also support your efforts and get involved. One of the things we try to do on these calls is to help connect all of us, right? Like if we strengthen our connections and we strengthen this, citywide, regionally, and statewide network, we can do better work, right? Like we can leverage and amplify everybody's.
I really think it's so important for sincere organizations, individuals, and anybody as a whole to network and partner. I don't even think that we can get through it. We are very active and very reputable in what we do, but it's through the love of people just coming together through this time that makes everything. It's so hard to explain. Like I have a organization that we partner with, and they're called Project Kind, and they are amazing, and they're like my right arms. And what we usually do is what I have, I share with them, and what they have, they share with us. So if people need food, I can provide food, and if they have clothing or whatever resources that we just share. And you have to kind of fight these these different things with love. You just have to come together, and the unison makes it so much easier for things to, just things to be better for everybody. So if anybody, if you guys want to reach out, or if you need help, we're located at 462 Sanford Avenue in Newark. We partner with Unified Wellsburg Services. They have blessed through Pam Daniels. They've allowed us to use their site. We operate from Tuesday through Friday. There's hot meals at deliveries to seniors and disabled who are homebound or can't get out. And people are also welcome to come in. You can come by and pick up a meal. But on Sundays at 3 p.m., every Sunday, we have a grocery distribution, and we give a lot. We had a clothing closet and all those things, but we're trying to practice as safe as possible. Everything is grab and go. Everything is prepared and ready for anybody to come and pick up. I'm just going to keep going. Maybe when this is all clear, then I'll sit down. And but I appreciate you guys inviting me on. I'm going to stay on a little while longer, and I want to hear some of the questions and get more information. So I don't want to talk too long.
Thank you, Tanya. Well, I'll turn it over to Casey to see if anybody has some questions for Tanya.
Absolutely. Excuse me. So just as a reminder, you can raise your hand. You can, through the participant section, you can throw your questions into the chat function. For those who are joining us by phone, you can hit *6 to unmute yourselves. While we're waiting for folks to formulate their questions, just to the point that you made earlier, Tanya, about needing some other emotional and mental support during these times. One of our participants dropped into the chat function the hotline for mental health cares, which is 866-202-HELP, H-E-L-P. We've done a previous call around mental health resources in our state. There's lots of hotlines. There are a lot of organizations through the New Jersey Mental Health Association, the Mental Health Association in New Jersey, for folks just to call, and it doesn't have to be, you don't have to have a diagnosis to do it. It's just additional support for, our everyday residents and for our frontline workers and first responders, because this work does take an emotional and mental toll for sure. So, for anyone on this call, if you are looking for resources and for help, they are out there, and that phone number is there. And then we can also send along to the mental health summary from our previous call that has a list of those resources in addition to that. And there's some other folks that are dropping in more resources in the chat, because it's really important to be able to take care of ourselves in this process too. So I'm just going to quickly look through here. We've got one question for Ms. Tanya. Ms. Tanya, does Treehouse Cares continue to accept donations? And if so, what is the best form of donation, and how would we get it to you?
Okay, yes, we're still accepting donations. We have a PayPal account people can donate to, and that's treehculturalarts@gmail.com. Or you can Cash App Treehouse Cares. Or if you have non-monetary donations you want to drop off. Right now, we recently partnered with United Way and the Salvation Army to receive non-perishable foods. But as of tomorrow, that their food distribution to us and other organizations will stop. They have been providing non-perishable boxes for almost 4 weeks now. And so we're in desperate need of non-perishable items. We do receive a lot of produce and vegetables, but if anybody want to donate any non-perishables, you can drop those off Wednesday through Friday from 3 to 6 p.m. at 462 Sanford Avenue, the UVSO Community Center.
Tanya, can you give us your email address again so we can put that in the chat function?
Sure, it's treehculturalarts@gmail. No donation is ever too small. Again, we're growing, the numbers are growing rapidly. If anybody want to visit our social media page, I have a Treehouse Cares page. You're welcome to go and visit that page. All the information is there. You'll see videos and photos of what we do. And I'll also share a lot of awareness of where we're going to be and the food distribution, because we're not just in Newark, but I distribute, I have an outreach in Wayne, New Jersey. That's every Sunday at 3 p.m. In New Brunswick, we have every Sunday as well. That's at 3 p.m. So I have different people at different, in different locations. But Newark is the main site.
Mm-hmm.
I offer if any families are in need of emergency food, we always try to provide that as well to parents, students of different schools, to anybody that needs, just they can reach us. I'll give you guys my phone number. So my number is 973-393-3449. If any, I get a lot of calls. I'm doing this and I'm watching my phone as well, because it's like nuts right now. It's nonstop.
Thank you, Tanya.
You're very welcome.
Thank you.
Very welcome.
And we also want to recognize and thank our friend and colleague Pamela Daniels.
Yes.
We first met doing our work in Newark, our Newark Call to Collaboration work, and Pamela is our co-chair of our Creative Newark Call to Collaboration. And Carrie Puglisi, who's also on our Newark host team. Carrie's on the call today. She's waving. We might have a couple of other Newark host team members on the call today, but Pamela is the one who connected us with Tanya and with Chris Pernell. So, we're really grateful to Pamela for working with us and, pulling this call together and designing this call. And she's going to work with us again for the call we're doing next week. Casey, do you see any other questions in the chat box before we start to wrap things up?
So we do have a couple of others from sort of previously that we can address. So a couple are, considering, our colleague Arlene, who is on the call with us today, said that, the prevalence of people with hearing loss are being impacted by mask use. And, the reality is that over 50% of seniors have hearing loss. So communication challenges are at every step. She wanted to share that just as general information for those on the call to remember that with seniors and with those who have hearing loss, these situations can be even more frightening because the communication level, decibel-wise and visually, just, becomes even more difficult to navigate. And then in addition to that, there's a question about, considering that disinvestment is a critical factor to healthcare and other issues, how do you take steps to bring voice to the issues and then tap into stakeholders with various resources to help with messaging and engaging to remedy and find and implement solutions? So it's sort of a broad question in terms of, I think, resiliency in general. So I don't know, Dr. Pernell, if you want to take that, or Tanya, if you want to address that.
I can say something to it. We have been very aggressive in getting the message out around what we've experienced here at University Hospital. So whether it's been in print media, our CEO did an op-ed in the Star Ledger. I've spoken with the Record. We're aggressively courting, through our foundation, I should say not the hospital proper, but through our foundation funders who definitely came through with resources related to the pandemic, but more importantly, to understand the narrative around how the pandemic has impacted Black and Brown lives, and especially what we're going to have to use for population health strategies, to do pop-up clinics. That's what I'm working on right now, to be able to raise pop-up clinics to go to where people are. If people are not feeling reassured to come to get care here, but to go to where there are in-home and telemonitoring. So we've been applying for grants and things of that nature, because in disinvested communities, whenever a pandemic or a crisis happens, it happens at a larger scale. So we have to build the virtual infrastructure so that communities can always stay connected, connected to care, connected to one another, connected to information, as well as building out those resources. Like we need a prevention army, a prevention force, like a prevention army of community health workers. And we'll need, policy changes around reimbursement and things of that nature. So we're definitely involved in policy advocacy and how community health workers can be used. We have community healthcare chaplains here at University Hospital. So using a mixture of CHWs and community healthcare chaplains, and how we can leverage those persons through these pop-up clinics and through phone calls. So yes, we're looking for funding, whether that's grants or whether that's philanthropic entities, to help realize some of those things I just said.
Thank you.
Great, thank you. We have one other question, I think from previously, which is, one of the participants has a sibling that lives with her parents who need to have lab tests because of the medications they're taking, but they're trying to get the medical attention, but there's a lot of fear around COVID-19. So what can someone do in a situation like that?
Yes, and I was trying to answer some of the questions that I was seeing myself and provide information and answers to it. Market studies have been done, and 7 out of 10 persons through a Kaiser Family Foundation study said that people said they recognized that their health was being impaired, but they were too afraid to get care. And that probably over the next 3 months, 7 out of 10 persons says, I will return to care. We are just starting to see evidence of people returning to care. And what we've done that has been helpful is to communicate to the community, what are we doing to keep you safe? If you have to come here, what are we doing to keep you safe? So we're doing quick commercials we put up on social media ourselves to show you what the process is, to show you what it looks like when you come in. If you have to go to the emergency room, the precautions that we're taking, everyone's being masked, everyone's having a temperature screen, we're screening for symptoms, we're cleaning aggressively. We show you the robot, we show you the wand that we use to clean rooms. We're testing any patient who comes to the ED that gets admitted. I think community needs to know what we're doing to keep them safe should they have to come here. And then community needs to know how to connect to providers through telehealth. So we're actually doing a lot of messaging to let community know these are the telehealth services that are available to you, to check in with your doctor. So for that family member that's afraid to get those elderly persons back into care, you can go to our social media pages. You can show any of the videos that we're doing here at university, even if that person doesn't receive care here, because a lot of healthcare institutions are doing that. And you can definitely, recommend telehealth as an option just to get a person checked back into care. A video visit, even a phone visit would be so important at this time.
Yep, thank you. I think there's one more. I know we're a few minutes over time, but if everybody's good, we'll I think there's one more question that just come into the chat box from our good friend and colleague, Debbie Duncan at Center for Nonprofits. Debbie says, how often can staff at University Hospital be tested?
So this is something that we're dealing with actively, right? And a lot of healthcare institutions are dealing with. At University Hospital, because we are an academic medical center, we have access to innovative research trials. Patients do, and then we had a healthcare worker study that was going on. So you could sign up where you were regularly tested as a part of that study to see if you had been exposed. Right now, what we're doing is we're devising a strategy for those who are in patient-facing areas of very high-risk patient populations, those who may be receiving organ transplant, or those who may be on chemo or receiving treatment for cancer. And those staff, we're going to start to roll out antibody testing, and from there, then serology, where we look at whether or not a person has been exposed, and then actually testing them for the virus in some repetitive fashion. I don't want to say we have it all certain, but we're ready to roll it out. Right now, we're thinking about a window parameter maybe every week, or that might change because the science is changing, right? And to see what's necessary. But the most important thing we can do is PPE. That is the most important thing we can do, and making sure everyone is masked and making sure everyone is exercising aggressive hand hygiene, and everyone is practicing physical distancing.
Right. Well, I know there's lots of other additional information that's in the chat box today.
Oh, unfortunately, I think Elizabeth's screen just froze. She'll be back in a couple of seconds, but I'll just take it from here for a moment. So there are lots of resources. As a reminder, we will be creating a written summary. There we go. We'll be creating a written summary of all of these resources. It will be emailed to all of you tomorrow. It will also be available on our website for anyone. We encourage you to share that widely, right? This information is useful for everybody. I will also be dropping in now just a few links for registering for our last call in this series next week, which Elizabeth is going to tell you a little bit about. My colleague Jeanette's also going to drop in all of the social media channels that we're doing. And Jeanette, I just want to turn it quickly to you if you want to say a little bit about those channels for people and what they can find there.
Sure. Hi, everyone. Hope all is well. I'm just dropping in the links to our social media channels. We are on every single one of them. So that's 5 of them. And then we also have 10 Facebook groups that you can connect to if you represent some of the different parts that that are listed. So thanks. Turn it back to Elizabeth.
Great. Thanks, Jeanette. So again, everybody please join me in thanking Dr. Chris Pernell and Ms. Tanya Veltz. You did tremendous today. We're so grateful to you for your time and your information and your expertise. Thank you again to our good friend and colleague Pamela Daniels, who helped us to design today's briefing. Thank you, Pamela. Next week, it was our planned final call in this series that we began on April 1st. And we've decided it won't be focused on COVID-19. We will have a racial justice conversation with all of you. So we've been inviting some of our colleagues around the state and communities where we've worked, who we know are advancing some racial justice work, to share a couple of words with us about what's happening there. So if any of you are involved in advancing racial justice in your own communities, please send us an email and let us know. But we want to have a conversation next week, and we want to hear about, the positive work that's happening and how people can get involved and be a part of this and stay focused on this work. So that's our call next week. Another quick reminder about the census, right? There's so much happening in our world, in our country these days, but we can't forget about the census too. I know a lot of you are working to make sure that, our really hard to reach community members are being counted. So, if there's other information that you feel like we can push out at Creative New Jersey, please reach out to us, reach out to Jeanette. She has access to a really wide network. So, let us know how we can amplify your work. We're so grateful to everybody that joins us every week and for all of the work that you're doing. So I think we'll adjourn for today. As you know, in Creative New Jersey style, we stay on the call after we stop recording so that if people want to do a check-in and let us know how you're doing, it's important to us that we hear from you. So we'll thank you all right now, and we'll end our recording and all again next week.
Thanks, everyone.
Bye-bye.
Bye.